Hello, this is a teaching video prepared by the Acute Care team, and today we're going to cover how to recognise different types of cardiovascular compromise or shock and how we can manage them in practice. What is blood pressure? Our blood pressure is made up of our cardiac output, which is the amount of blood pumped per minute, usually around 4 to 6 litres, multiplied by systemic vascular resistance, which is the resistance the vessels exert on blood flow. MAP, or mean arterial pressure, is the average pressure exerted during a cardiac cycle and should be maintained above 65 to ensure adequate organ perfusion and oxygen delivery. This is a very simplified diagram of our cardiovascular system and illustrates the factors that affect cardiovascular efficiency. Firstly, preload, which can be defined as the amount of stretch on the cardiac muscle fibres proportional to the amount of blood returning to the heart, which means the more stretch, the more volume that's ejected. Contractility, which is the effectiveness of the heart as a pump. And afterload, which is the resistance offered by the vessels, and it's the force or load against which the heart has to contract to eject the blood. Any alteration or failure of preload, contractility, or afterload can result in inadequate tissue perfusion and lead to organ dysfunction and eventually shock. Shock is defined as failure of the cardiovascular system to deliver oxygen and nutrients to meet cellular metabolic need. Establishing which type of shock we're dealing with can enable us to manage it appropriately. We can do this using the ABCDE approach. Today we're going to cover 4 different types of shock. Firstly, hypovolemic shock, which is caused by severe blood or fluid loss, just from a traumatic bodily injury. This makes the heart unable to pump enough blood to the body to distribute oxygen. Cardiogenic shock happens when the heart is damaged and unable to supply sufficient blood to the body. This can be as a result of a heart attack or congestive heart failure. Septic shock is a form of distributive shock and is a systemic inflammatory response to the presence of infection. Common causes of this could be pneumonia or a UTI. And anaphylactic shock, another form of distributive shock, is a type of severe hypersensitivity or allergic reaction and can be caused by allergies to insect bites, medicines or foods. The different types of shock can affect different parts of our cardiovascular system. So hypovolemic shock affects preload, cardiogenic shock affects contractility, and distributive shock, sepsis or anaphylaxis, affects afterload. The first type of shock we will cover is hypovolemic shock. Patients at risk of hypovolemia as a result of major hemorrhage include those on anticoagulation therapy, patients that have undergone trauma, and post-surgical patients. Symptoms we would expect to see in the actively bleeding patient will be tachypnea, tachycardia, an increased CRT. The patient may appear pale, cold, and clammy. Their blood pressure will drop, although this is often a late sign. Their pulse will feel weak. They may have an altered level of consciousness and go into peripheral shutdown. The first step in the management of a major hemorrhage is to ask for help. You can activate the major hemorrhage pathway on either 2222 within Shore Trafford or 4444 at Oxford Road campus. If the blood loss is over 1.5 litres and ongoing, or there's ongoing blood loss with hemodynamic instability, so if the patient is showing signs of shock. All details of the massage hemorrhage action cards should be on the staff intranet and on all your resus trolleys in clinical areas. In the case of major hemorrhage, we've established the first thing we need to do is summon help. We're then going to use the ABCDE approach to assess the patient and administer interventions. Firstly, start high flow oxygen at 15 litres a minute via a non-rebreathe mask. Establish observation monitoring. Gain wide route access and take relevant bloods. We've included a box at the bottom of the slide with bloods that you would want to take to monitor the patient's condition. Give bolus fluid, starting with crystalloid fluid, sodium chloride, 9.9%, and then considering whether you need emergency blood. Activating the major hemorrhage protocol will also help you with that. Keep the patient warm, consider tranexamic acid, vitamin K, calcium chloride, and consider whether you need to talk to haematology. Now we're going to talk about cardiogenic shock. Examples of acute cardiogenic episodes are acute MI, heart blocks, arrhythmias, and LVF. Symptoms that you might see in these patients are central crushing chest pain. The patient may appear sweaty, clammy, cold, a high or low heart rate, an irregular pulse, tachypnea, a low blood pressure, and patients might have a sudden oxygen requirement. The aim of treating cardiogenic shock is to reduce cardiac workload. This will reduce the systemic vascular resistance and increase the amount of oxygen getting to the organs. As always, the first step is to summon help, so dial 2222 for the cardiac arrest team. You may also want to alert the parent team and involve cardiology. We're then going to use the ABCDE approach to assess the patient. As always, start with high flow oxygen at 15 litres a minute via a non-rebreathe mask. There's a caution here, avoid oxygen in MI cases as this can cause coronary artery vasoconstriction, so always check the patient's saturation level and take a gas so you know what's going on. Establish monitoring, gain access, take bloods. There's a list here on the right hand side of the slide with bloods that you may want to take in this situation. Consider taking an ECG. We're then going to use the mononamonic to treat the patient. So morphine and metoclopramide for pain management and nausea. Oxygen. Nitrates are going to increase the blood flow to the heart and prevent pain. And aspirin as well. As this is not a circulating volume issue, it's a contractility problem, we're going to avoid giving fluids to this patient. And we're going to consider pulmonary edema because we may need to offload. We're now going to talk about distributive shock, which includes septic shock and anaphylaxis. We're now going to talk about the septic patient. Firstly, it's important to differentiate between what we mean by infection and sepsis. Infection is defined as an inflammatory response to the presence of microorganisms. Sepsis, however, is a systemic inflammatory response in the presence of infection and causes multi-organ dysfunction in the body. Septic shock is sepsis with hypotension that remains despite fluid resus and may require vasopressors. So who is at risk of sepsis? As you can see from the slide, it can be the very old, the very young, those that are pregnant, and anybody that's immunocompromised, so those undergoing chemotherapy. But it's important to remember that all of our patients in hospital can be susceptible to sepsis. So what kind of signs and symptoms do we see in septic patients? They may be tachypnic, tachycardic. They often have a reduced CRT, a bounding pulse, and they may appear flushed. Temperature may be high or low, and they may also have an altered level of consciousness. and, of course, a low blood pressure. So how do we treat the septic patient? Firstly, summon help if needed. Perform your ABCDE assessment. Give high flow oxygen at 15 litres via a non-rebreathe mask. Establish appropriate monitoring. Gain IV access and take bloods, including a venous blood gas for your lactate measurement. Take blood cultures and culture any other appropriate sites. Give a fluid challenge, which is 500 ml of sodium chloride 0.9% over 5 to 10 minutes. Give antibiotics, check microgride or confirm with the ward pharmacist. You may need to catheterise the patient, but ensure strict fluid balance monitoring. Remember, you've got 1 hour to complete the sepsis 6 in the case of red flag sepsis, so it's important that these elements are done quickly. Your sepsis screening tool will help guide decision making, and it's really important to remember that a normal temperature doesn't exclude sepsis. And antibiotics should never be withheld if you're waiting for bloods or cultures to be done. Lastly, we're going to talk about anaphylaxis. Anaphylactic shock can result from allergies, insect stings, food, medications. In order to manage anaphylaxis, it's really important to remove the source if possible. Summon help using 2222 for the cardiac arrest team. Perform your ABCD assessment, give high flow oxygen, and manage the airway appropriately. Your 3 main drugs are adrenaline IM, chlorpheniramine IV, and hydrocortisone IV. Make sure you establish appropriate monitoring, gain IV access, take bloods, take a VBG, give a fluid challenge as we've discussed throughout the presentation. Not all areas have anaphylaxis kits in their research trolley, but all areas should have action cards for you to go off. To summarise this presentation, remember, get help early, use the ABCDE approach to assess your patient, don't rely on early warning scores, always use your clinical judgment as some patients compensate. Use action cards and policies to aid your management. Thank you for listening. We hope this has been useful. If you have any further questions or queries, please contact the acute care team via email.